Good evening, everybody. Welcome to this UROWebinar, which is dedicated to the follow-up of non-muscle invasive bladder cancer. My name is Paolo Gontero from Torino, Italy, and this evening I have the privilege to chair this webinar with an outstanding group of experts in the field. So we will start with what the guidelines say about the follow-up of non-muscle invasive bladder cancer, which you will hear involved a lot of cystoscopies. And then, of course, we will move on whether we can de-intensify this follow-up by using new markers. We have new evidence. And then, of course, new methods, whether they are effective to do a more refined follow-up. But finally, we will have also the patient view. And so we will be very, very lucky to hear what really the patient would like to the follow-up to be. So let's just get started. Professor Morgan Ropré, he doesn't need an introduction. He's a professor of urology at the University La Sorbonne in Paris, and he is also the editor-in-chief of European Urology Oncology. He will actually address what is the standard of care follow-up for non-muscle invasive bladder cancer according to the EAU guidelines. Thank you very much, Morgan, for being here this evening.
Thank you, Paolo. I was belonging to the panel of the guidelines for many, many years. And now I'm sitting as editor-in-chief, receiving a lot of papers. So reading really the papers from the guidelines and reading with a lot of attention what we should do. I have to say something. Today, the strategy is much more eminence-based than evidence-based. So we will have a look. It's a very good moment, an opportunity for us to discuss bladder cancer issues because there is a lot ongoing in the pipeline of therapeutic strategies in bladder cancer. Probably there is a window of opportunity to refresh a little bit the way we follow up non-muscle invasive bladder cancer. These are my conflict of interest, as stated by Professor Gontero. I work in Paris, Sorbonne University at Assistance Publique Hôpitaux de Paris. So we are talking about urothelial carcinoma. We all know that the phenomenon is mostly triggered by the consumption of tobacco, and there is a growing phenomenon which makes it an endocavitary disease because we are talking about what we call previously superficial disease, which is in the bladder reservoir. So the question today is how do we follow up on non-muscle invasive bladder cancer without, I would say, skipping the possibility to have a tumor in the upper tract and a micrometastatic dissemination. Because as a urologist, we will of course focus on what's going on in bladder reservoir, but we should be aware of the possibility of the disease to disseminate, even though it's very rare in the field of bladder cancer. The old EORTC stratification was giving us this kind of picture, which let us know that there are two kinds of diseases. The low-grade disease, which is something which is not threatening the life of the patient, but probably threatening the quality of life because it's coming back and forth, but the ability to progress is very low. And the non-muscle invasive bladder cancer, which are the high-grade or high-risk category, and which is a very dangerous disease as soon as it can progress and evolve to a muscle-invasive stages. So what tools do we have? We have online tools, which are calculator coming from the EORTC with a number of criteria. You can see the number of tumor, the tumor diameter, the fact that it's a primary tumor, the stage of the disease, the existence of a CIS, tumor grade, and the calculator will give you the ability of recurrence at 1 year and 5 years, recurrence and progression calculator. So the most favorable NMIBC has a 30% 5-year risk of recurrence. So all the non-muscle invasive bladder cancer should be followed up on. It's impossible to say to a patient, the tumor has been removed, I will not see you again. But we are not dealing with the same kind of disease according to the category, as I mentioned, where the NMIBC is liaised to. So the low risk, intermediate, high risk, and even very high risk. The stratified follow-up approach is a strategy to see whether you could be starting a light strategy of follow-up or a very intense strategy, because we are in a moment in time where new tools such as the markers could be incorporated in the follow-up. And obviously, we will not define the same strategy according to the risk group category. So what is clear today is that all patients need follow-up, even for the sword of Damocles above their head that you trigger with the word cancer and the anxiety. So you could not let a patient alone. Frequency and duration need to be, I would say, reflecting the individual risk, and missing a high-grade non-muscle-invasive bladder cancer has to be avoided because we are at crossroads to the progression towards the muscle-invasive bladder cancer stage. The limitation is coming from the lack of RCT to safely reduce current schedule. So first cystoscopy is extremely important. It has to be done at 3 months. And as you can see for big trials, this one is from Juan Palau from Barcelona, that the risk ratio of recurrence at 3 months is the higher. 3 months recurrence has more impact even in the definition of patient refractory to BCG or resistant to BCG. Remember, this cutoff at 3 months is very important. What is the timeline and what are the tools that we will use for the follow-up? Urine cytology, cystoscopy, and do not forget that we are dealing with upper urothelial carcinoma. So the urothelial carcinoma can be in the urethra, but can be also in the upper tract. It's impossible to skip the vision of the upper tract imaging. A CT urogram should be every year. For high-risk non-muscle-invasive bladder cancer, you will not use the urine cytology in every situation. Do all NMIBC require intense follow-up? The answer is probably no, because you see that according to the risk, a less intense follow-up can be proposed for low and intermediate risk, because the ERTC calculator are keen to propose, I would say, a more favorable outcome. When to end the follow-up and to stop it in low and intermediate risk. You see in that trial with 200 patients, all treated with BCG, the recurrence free in low risk was very low. High risk NMIBC has to be followed up for a long period of time, and it has to be a lifelong schedule. So you cannot let the patient alone. So the follow-up cystoscopy is totally different according to the risk group category where the patient is belonging. And I believe that this slide is the most important one. If you want to stick with the guidelines, you have the rhythm of the schedule and the intensity, the necessity to add cytology to cystoscopy, and to add upper tract imaging. For the last version of the guidelines, the pocket guidelines that we have, you have this table, which is very clear with the rhythm and the imaging. The problem, as I mentioned, is the grade of recommendation and the quality of the evidence that we have. And as you see, the cytology, which is the only markers validated in the guidelines at the moment in time, is very important when it comes to the follow-up to the high risk and very high risk group. Cystoscopy appears to be the standard. The problem is time consuming. The patient come back and forth to your I would say, medical units, and it's expensive. A lot of people surrounding you, the nurse, even if you use a single-use cystoscope, it could be an issue to the economic and impact and the carbon footprint. So it's very important to consider that it could be nice to reduce the rhythm of cystoscopy. Urine cytology has several drawbacks. It appears to be the standard marker today, but several drawbacks. Need for highly trained cytopathologists, and as we know it already in prostate cancer, there are discrepancies among observers when it comes to urine cytology between pathologists, and so the reproducibility is not that good. So you cannot rely only on one single person. Urine biomarker at the moment, it's ready probably for prime time, but because we have genetic-based markers, the question is the cost. The question is, of course, the reimbursement, especially in Europe, and the way we incorporate it into the schedule of surveillance, but we will discuss that further. The ability to avoid cystoscopy is our ability to integrate some markers with a high negative predictive value and high sensitivity when it comes to a high-grade tumor. So is it a cherry on the cake, or is it something that it is going to replace the cystoscopy? On top of that, when you had a marker in the strategy, is it fair to compare it with the cystoscopy because it's the human eye that is going to watch through the cystoscope versus a DNA test, which is going to be sometimes positive, the cystoscopy is negative, but does it mean that the test is positive in advance of the cystoscopy, which is too early in the natural history of the disease to depict a tumor? There are several tests. We'll go very rapidly on that. But at the moment, you can consider that certain tests are more performant in the low-grade category and some other in the high-grade. And what is important is to understand that there is not a single test that is relying on one single marker, but on a panel of markers. That is important. So if the patient refuses cystoscopy, or if we are in a situation where there is impossibility to do cystoscopy, remember the COVID-19 outbreak, then the marker strategy appears to be very appealing and interesting. And this is the kind of, I would say, flowchart that you could follow or propose in the way you could follow up on the patient with non-muscle invasive bladder cancer. So to conclude, it is obvious that we need follow-up on patient with bladder cancer. The first 3-month cystoscopy appears to be crucial since it provides very meaningful information in terms of prognosis. The urine cytology is currently integral part of follow-up, but it could be challenged. And imaging to rule out upper tract tumor or concomitant or metaclonus upper tract tumor is extremely important. Currently, no biomarker can replace cystoscopy, but it should be considered to be incorporated in the follow-up that we propose to our patient. This is the challenge of the webinar. I open the floor to my colleagues. Thank you very much.
Thank you very much, Professor Upre, for this, for clearly pointing out what is the current standard of the follow-up. Just briefly, Morgan, do you think, irrespective of the new evidence of marker that we are going to discuss later, but do you think that probably in light of the advent of active surveillance, the follow-up, the current follow-up for non-muscle-invasive bladder cancer at low intermediate risk is probably excessive? This is a little bit a provocative question, of course.
No, I think there is room for de-intensification, and it's probably the best spot to do that because we are I would say the bladder is not at stake there, and I mean if we miss a low-grade recurrence, we can still put the patient back in the OR. So the natural history of the disease is not threatening the patient at this stage. So I think that probably for many, many years, we have done probably too much in this category of patient. And I would be confident and I would be happy to try to decrease or to diminish the number of cystoscopy that we are doing in this category. I would be dubious or curious in the manner we should proceed in high risk and high grade bladder cancer. So I would be honestly totally confident to do that in that category of patient.
Thank you very much. There was actually a question on urinary marker use, but I would actually move to the debate. And now we have debate on, of course, what is the place of urinary marker. And Professor Witches, former professor of urology at the University of Nijmegen, will actually defend the position of using urinary markers as a way to de-intensify the follow-up, whereas Professor Laura Mertens, professor of urology at the Netherlands Cancer Institute, will actually defend the opposite thesis, that urinary markers are not yet ready. Please, Professor Witches, you can start your part. Thank you.
Okay, Paolo, thank you very much. So I will try to defend the reason why we shall be able to de-intensify the follow-up. So I'm going to defend the urinary markers that can safely be used to reduce cystoscopies. And I think the time has come. I have no conflicts of interest, although I've been doing marker research for, I think, around 30 years. And I have to say, finally, I think we are ready for using those markers. It's prime time to do that. I'll try to show that to you. So Morgan already showed you the things we do for follow-up of bladder cancer, non-muscle-invasive bladder cancer. We do a cysto-invasive, not a very good sensitivity. We know that from the studies with blue light. Cytology, good specificity, but not a very good sensitivity. And imaging, basically for high risk, of course. And then again, it is ultrasound, CT, MRI. And the reason that those studies show that it's not that good, it's all based on visual interpretation. And you all know that the visual interpretation is, of course, subjective. You see on the right a nice slide where some of you will see a skull and some others will see a lady who is doing her makeup in front of a large mirror. So our visual interpretation, of course, remains subjective. So what are the results of the current epigenetic markers? And like Morgan said, those are multiple markers used in a marker set for follow-up, where the negative predictive value, of course, is important. Here you see a quite recent review of Ekaterina Latina, and she looked at 1,000 patients, and you see there the recurrences missed, which, if you recalculate that, is actually the negative predictive value of these new markers. You'll see 5 of those is all around 95 or even higher percent, and that's for all. And if you would go for the high-risk tumors, then this negative predictive value is even higher. So, for example, for the Euromonitor, it's around 99% negative predictive value, meaning if the marker is negative, the chance that you do have a tumor is very, very, very small. And of course, Laura's argument will be, like Morgan said, what's in the guideline. Consequently, markers are not, of course, currently be used to replace cystoscopy and follow-up. There is already a nonetheless. And the nonetheless says you maybe can use one in some patients because they do have a very high negative predictive value. And I think that's, of course, true. I think the final proof is a very recent study, the WK study 15. It's a randomized controlled trial where they used the expert bladder cancer monitor test, and they alternated that with cysto versus only cystoscopy, which is, of course, the guideline advice during follow-up in previous high-grade non-muscle-invasive bladder cancer. And you see that the number of recurrences that were detected were the same in both arms, 22 versus 21 in the standard arm. There were 2 high-grade recurrences missed by the marker, which you, of course, pick up the next time when you do a cysto. And the number of cystos was impressively lower in the marker arm, 445 versus 1,029. And then, and I'll come to that a little bit later, there is also an anticipatory positive effect. So some of the patients that had a positive marker but a negative cysto were due to have recurrence very soon after that checkup. My editorial conclusion to that article, which has recently been published, is that urine markers are, of course, safe, cost-effective, and convenient. They can potentially predict future recurrences, which may help in tailoring follow-up. And again, I will come to that a little bit later. And I think the AUA conclusion that we still can't use them, I think it's not future anymore. I think the future has arrived. How we implement in my clinical practice. So we started using a test in February 2020, when there was a COVID, and we were actually not allowed to see patients in the outpatients. And we just had finished the ApiCheck test, so that's the test that we start using. And actually, we now alternate an ApiCheck home test with cystoscopy, so the test is done at home. Patients send a urinary sample to the laboratory, and we do a telephone consultation to discuss the results. And, if it is positive, we can still ask them to come to the outpatients for a cystoscopy. So that's actually a very convenient way of doing that. And the results are the patients are happy, they don't have to travel, no discomfort, no time off work. We are happy, we have reliable results, we have time to do something else. We still have the telephone consultation if you look at reimbursement and money. And of course, it's cheaper. You don't use a scope, you don't use a nurse, you don't use a room, there's no traveling, etc., etc. And you see that in the manuscript by Charlotte Ekman, you see that we looked at that in my practice, and indeed, using that test in an alternating way is macroeconomically absolutely cheaper than doing only cystoscopies. So the advantage is based on these results that since October 2023 in the Netherlands, tests are reimbursed in follow-up of bladder cancer. That's of course a major thing. Then Laura's second argument might be those false positive results. Beware, if the test is false positive, you would have probably had a cystoscopy anyway. But here you see the false positive results of those tests. It's the same review, and that is about 50 to 30% false positivity of these new tests. And again, note the patient would have had a cysto otherwise anyway. So that's probably not a major issue. But here you see, and for the older ones amongst us, you see that the Eurovision test also was able to more or less present the recurrence. You see here in the end that the recurrences in a positive versus a negative test were much higher in the positive group. And we have the same result now for both the bladder API-check and the expert. You see here that in those patients with a positive or negative test, the chance of having a recurrence in the near future within 12 months is 5, in this case 3, but let's say around 5 times as higher as those patients that have a negative test. So the false positives are more or less anticipatory positive. And of course you can do, that's in this slide, and probably Professor Maria Pan will talk about that. If the test is positive, your cysto is negative, you might do a biopsy, or in the best case scenario, something with blue light. But anyway, it also might influence your follow-up strategy, that you might not send the patient out of your outpatient for 6 months, but maybe 3 months. Anyway, for me, in summary, urinary markers are convenient for the patient and the urological professional. They are reliable. I might think they're better than MRI. And all, they are cheaper, potentially anticipatory effect. And if that is, you can follow up, you can adapt your follow-up schedule. So for me, it's a perfect and safe way and a smart way for the intensification of follow-up. And with that, I thank you for your attention.
Thank you very much, Fred, for giving your point in a very, very clear way. And now, Laura, tell us why you think that urinary markers are not yet ready for prime time in the follow-up of non-muscle invasive bladder cancer.
My position actually simple. Using urinary markers to reduce cystoscopies in non-muscle invasive bladder cancer surveillance is premature. I have no conflict of interest. Fred thought I was going to be predictable, but I do think I have some new arguments for you. I mean, we all want fewer invasive procedures. We all want care that's more patient-friendly, and we all want healthcare that stays affordable. But handing over follow-up to urinary markers today means risking exactly what matters most, and that is missing high-grade disease. Yes, I agree, markers are promising. Yes, the BLACA15 trial is important, but feasibility, in fact, is something completely different than policy. Feasibility is not policy. And also we must ask, is this approach truly more patient-friendly? Is it really what patients want? And will it be cost-effective in the long run? So in my opinion, we should instead focus on smarter, more targeted strategies to achieve the same goals. And indeed, I will start with the guidelines, because I cannot repeat it enough. What do the guidelines say? Both the AUA and the EAU guidelines are crystal clear. Do not replace cystoscopy with urinary markers. Do not use markers. So if you argue that markers should replace cystoscopies, you're not just going against me, you're going against every guideline panel we have in the world. So first message, stick to the guidelines. And the important reason for this is accuracy. We know that marker sensitivity is far from ideal. For high-grade disease, sensitivity is reasonable, but once you look at the whole group, performance drops dramatically. So with markers, you will miss recurrences. And high-quality studies on markers in practice were lacking. But then came the BLACA15. Fantastic study from Denmark, the only randomized controlled trial we have. So the only trial. They cut cystoscopies by more than half. Impressive indeed. But at the same time, 2 of the 22 high-grade recurrences were missed by the marker. That's not a footnote, that's the essence. So you not only miss recurrences, you miss important high-grade recurrences. And there are more major limitations. First of all, the recurrence rate in the BLCA15 was far lower, was 12%, compared to the 50% recurrence rate that they anticipated and expected, 12 versus 50. This is a crucial detail because recurrence prevalence directly drives the predictive value. I mean, as recurrence increases, the negative predictive value, which we all think is very important, falls. So in a population with more disease, a negative test is more likely to be false negative. So is the marker strategy really that good? Or was it biased by the study population? How generalizable are these results to real-world populations with higher recurrence rates? Many questions, no answers yet. And also, follow-up was relatively short, only 2 years. Even the authors themselves conclude, and that's not me, that's the authors of the paper, that long-term oncological safety must be validated before implementation. And if the authors themselves draw this conclusion, I think we can only agree that one promising trial does not justify a definitive practice change. And then another point, patient burden, patient preference. We constantly assume that patients find cystoscopies terrible and that they want fewer of them. And if that were really the case, we should take it seriously, of course. But is it actually true? In fact, there's very little research on this. One interesting study, a randomized controlled trial on pain perception during cystoscopy, found a mean VAS score of 1.9. And to put that into perspective, that's about the same as the sting of a mosquito or the discomfort of sitting on a Lego brick. And beyond that, the most important thing patients apparently want, and this is written in the guidelines, is certainty. They prefer certainty over the burden of a cystoscopy. Unless, that's what the studies show, a test reaches at least 90 to 95% sensitivity, we cannot offer that certainty. So the bar is very, very high. We've not met it. And until then, to be honest, who are we doing this for? Then the costs. Healthcare must remain affordable. And it's easy to say that markers will save money. But that claim must be quantified. And this should be done before implementation. But also this is unclear. In my own center, for example, cystoscopies turned out to be cheaper. And let's not forget, markers also bring false positives, extra workups, and the moment you delay a progression, every saving evaporates, of course. And here's a provocation. If our real goal is reducing unnecessary cystoscopies, do we need markers? And the answer, in my opinion, often is no. One recent study shows that the majority of NMIBC patients actually undergo way more cystoscopies than recommended. There's overuse in 75% of patients. So we can significantly reduce cystoscopies by just sticking to the guidelines. Combined with advances to improve the quality of cystoscopy, this means that our biggest gain is stopping overscoping, and we can also reduce low-value cystoscopies by risk-adapted scheduling. In the EU 2025 guidelines, there is a pragmatic de-intensification framework, and a lot of work is currently being done to safely de-intensify follow-up. And filling up that hard-earned profit with expensive markers is simply not smart. We need smarter schedules, not more markers. So check smarter, not harder. So in conclusion, yes, the BLCA15 is great, but the question is not whether markers can reduce cystoscopies in a trial. The question is whether it's wise and meaningful for the patients to do so today. And the answer, in my opinion, is no. Thank you very much.
Thank you very much, Laura, for your strong defense against markers. So for the sake of time, we should go on, but I think I would like to ask both of you a couple of questions that came up from the audience. Somebody asked, would you discontinue follow-up in a high-risk non-muscle-invasive bladder cancer after 10 years of no recurrence? Fred?
I think I would go on with a marker, or if you don't have it with cytology, but I don't think I would do still cystoscopies.
Laura?
I wouldn't use a marker, and I think it also depends on the patient's age and anxiety, for example. But I agree with Fred that you could consider to stop. Yeah.
And Laura, a patient comes to you and he says, I don't want to have a flexible cystoscopies, whatever, or is a frail patient. Would you consider a marker?
You're asking me the question, right? After my presentation.
Yes.
I mean, there's always reasons why you could consider a marker, especially if it's
It was a
being
question
nursed.
from the audience, by the way.
Yeah, I mean, you can always consider using a marker. I'm not saying that you should never use it, but if you would ask me if this is the moment to replace cystoscopies with a marker, then I would say no. But of course, there's exceptions.
But I think that we all agree that things have changed since the marker we had a few years ago. So
Yeah.
the story is different at the moment. Whether we can integrate in clinical practice, of course, remains to be demonstrated. But I hope we will have some more time for the discussion at the end. And now we move on. Professor Mariappan actually will discuss if and when we may use some actually more refined, more complex follow-up, like using optical enhancement cystoscopy. Thank you very much, Param.
Professors, thank you very much. Thank you so much for the kind invitation, and it's always a pleasure to be part of the European School of Urology webinar program. It's great to see all of these lovely presentations, and I hope I can bring through a bit of the discussion around the biomarkers along with optical enhancement before I finish this talk. So here are my conflicts. Now, colleagues, we really have two purposes for the surveillance. The first thing is to identify recurrences effectively and efficiently quite early. The second bit is obviously to identify, are there any poor prognostic features that could help us decide on the adjuvant treatment, perhaps maybe stopping adjuvant treatment and thinking about cystectomy, but also don't forget thinking about additional de-intensification such as active surveillance and office fulguration. We know there's a problem with white light cystoscopy. If you look at this image with white light cystoscopy on the left and the right side PDD, there are lesions that are missed, and we know this. We also know that there are residual cancers found at the time of re-resection, which are missed with the initial TURBT. No matter how well they've been done, there is a spectrum of residual cancer. And we know from cystectomy series, about half of these patients' CIS that are found at cystectomy have been missed at the time of the TURBT and biopsy. So the problem here with the surveillance is that there is false positives. We want to try and reduce false positives. It's not very dangerous, but it is not cost effective. You are going to end up carrying out more biopsies and unnecessary TURBTs. But the danger here is false negatives. You are going to miss cancers, and particularly missing cancers such as CIS or lesions within the prostatic urethra can be very, very dangerous and life-threatening. So these are the two things that we want to try and reduce. We've shown previously in this double-blinded study that we are reasonably good at predicting the stage of the cancer. We can differentiate effectively between muscle-invasive and non-muscle-invasive cancer in new tumors, but our grade prediction is quite deficient. We also know from the series from Memorial Sloan Kettering that they're quite effective in identifying tumors which are recurrent low-grade cancers. 93% of the patients with stage TA cancers were identified accurately, and when you've combined it with cytology, about 99% of these cancers were accurately detected as low grade. This is on white light cystoscopy. Are there adjuncts? So to identify grade and stage, these are some of the things that I would suggest that you read this nice review article that was published last year in the BJUI. So these are some of the techniques that are available. I'm not going to go through all of these things with the interest of time, but the optical coherence tomography has been described as the most accurate in being able to predict stage and grade, but is obviously limited by early stage data. what we need to focus on is being able to detect cancers. So the detecting recurrences. So we have SPIES, we have narrowband imaging, we have photoacoustic imaging where an ultrasound scan is applied on the flexible scope, and of course, photodynamic diagnosis and scanning. Among all of these studies, we have PDD, photodynamic diagnosis, and narrowband imaging, which have been studied extensively. And if you look at the most recent meta-analysis published in about 4 years ago, white light cystoscopy has poor sensitivity. Narrowband imaging and also PDD improve that sensitivity and being able to diagnose. But when it comes to identifying higher grade cancers, PDD seems to be much more effective with a sensitivity of about 93% compared to white light of 73%. PDD identifies more lesions which are high grade and CIS. And this is a nice meta-analysis now published almost 10, 12 years ago by Max Berger, one of our colleagues. But if you look at this image here, I've got a video, and you can see here with the white light cystoscopy, you miss the CIS, which is quite evident. And very typically CIS brushes off, which is why cytology becomes positive. And we know when we look at lesion-specific studies from a combination of studies, 62% of CIS lesions are missed on white light cystoscopy, and that translates to about 30% of patients being missed. So Professor Wittes led on this work where we made some recommendations on the use of PDD with surveillance. And it's largely based on re-resections in patients who've got high-grade non-muscle invasive bladder cancer surveillance, especially when you suspect CIS. At re-resection, having PDD will help. And also during surveillance of patients post-BCG, because we want to identify CIS. So essentially, surveillance with optical enhancement is recommended in patients with high-grade surveillance where it is more likely to be cost-effective. We obviously carry out more flexible cystoscopies, and this is a nice meta-analysis, again, a review of several publications. The flexible cystoscopy with blue light cystoscopy or PDD identifies more papillary lesions. And if you can look at this graph here, it shows more CIS. But the analysis shows that the numbers needed to treat with blue light cystoscopy to detect one additional recurrence over white light cystoscopy, you have to carry out 100 blue light cystoscopies to identify a papillary recurrence and about 50 flexible blue light cystoscopies to identify CIS. And rigid blue light cystoscopy has been shown from the meta-analysis to be better than flexible blue light cystoscopy. So it really hasn't become mainstay practice, and especially in Europe and definitely not in the UK. What about the timing of blue light cystoscopy? Obviously, this is important, especially if you're keeping an eye on patients post-BCG. This is a nice study that was published about now 15 years ago, which shows from 522 patients, the false positive rate after BCG drops at about 10 weeks and continues to be low at about 3 months. So generally we'd advise don't do a blue light cystoscopy inside of 6 weeks from the completion of the BCG. And finally, of course, what is important, we heard about biomarkers. Can we combine biomarkers with optical enhancement to make it more selective and nuanced and perhaps de-intensify the surveillance? The problem with the biomarkers is that we have something called anticipatory positive. What it means is that the white light cystoscopy negative at this stage with a biomarker being positive may turn out to be cancers, especially when you use DNA methylation or DNA biomarkers. They may become positive about 12 months later. And this is what is referred to as anticipatory positive. So what we did was we embarked on some work with the biomarker called EpiCheck. Professor Wittes I mentioned that earlier on. So in over a year, we followed up patients who have got high-risk disease, and in patients who are suitable, who met the inclusion criteria, had a white light cystoscopy along with EpiCheck being sent off. EpiCheck came back later. And in those patients with EpiCheck positive and white light cystoscopy negative, they had a PDD-guided biopsy. And what we found was this, and the circle bit is probably the most important thing out of about 316 patients. In patients with negative white light cystoscopy and a positive EpiCheck, what we found was The EpiCheck identified about 20 out of the 21 patients who had tumors found at white light cystoscopy. But once you turn on the blue light, you see an additional 17 bladder cancers found with BE plus PDD. What is more important is we're identifying a significant number of high-grade disease, and most importantly, the CIS that are being missed. I'm not going to go through the details of this, but essentially from the analysis, we found that 71% more high-grade recurrences were detected when we used PDD-guided biopsies triggered by bladder EpiCheck. And with performing BE and followed by PDD-guided biopsies, we could potentially reduce the number of unnecessary cystoscopies, but most importantly, by being able to pick out CIS, we could offer the patients bladder-preserving options. So in summary, colleagues, a whistle-stop tour on biomarkers and the use of optical enhancement. Essentially, the surveillance of the bladder is as important as managing these bladders with resections and intravesical installations. The use of photodynamic diagnosis and narrowband imaging could be useful adjuncts to the white light cystoscopy. The timing of doing the optical enhancement is important to improve accuracy. We have to start thinking outside the box and be a bit more innovative, like, for example, using biomarkers in combination with optical enhancement. But in the end of the day, the surveillance has to be sensible, it has to be cost-effective and more nuanced and selectively chosen for a specific patient and healthcare system. Thank you.
Thank you very much, Param, for this very, very interesting overview on how to integrate optical enhancement in the follow-up. Just briefly before we move to the patient perspective, how actually you would do in clinical practice? How would you manage all these new things, markers and optical enhancement in the follow-up? I understood that it's focused on high-grade disease, the follow-up of high-grade disease, but how in practical you could make it cost-effective in today?
Yes, so we have embarked on some cost-effectiveness analysis as well, Paolo. It's quite challenging. Obviously, we are dealing with biomarkers which have its own cost, an additional cost on top of white light cystoscopy, and also the, say, technologies such as PDD, which have an additional cost as well. It's also variable in different healthcare systems. So it's quite a complex process to make all of these calculations. I think in trying to be more selective with the patients that we're using them on, and that's why we went on to the high-grade patients rather than low or every patient on surveillance. We really can't afford it. So I don't think it's affordable to everyone, but it may be opening up avenues for us to explore the use of a combination of biomarker and optical enhancement.
Okay, thank you very much for this clarification. And now we move to the patient view. How much risk the patient want to take? Because we heard about the fact that patients actually really are not so worried about having frequent cystoscopy. Dr. Edoardo Fiorini, who is president of Palinuro, who is an association, Italian association, National Italian Association devoted to patients who have urothelial cancer, but he is also patient representative for the EU guidelines for non-muscle-invasive bladder cancer and UTUC. Dr. Fiorini, thank you very much for accepting our invitation, and please give the patient's view.
Good evening, and thank you for the kind invitation. The title of my presentation is a question. How much risk is a patient willing to take for a less intense follow-up that avoids frequent cystoscopies? The answer to this question is apparently obvious. I could answer it without asking to anyone. Probably you can do the same. But the patient's expectations, desire, and hopes are not so obvious and predictable. So I have preferred to ask this question to a number of Palinuro members who are directly involved in this disease. In the last July week, so we have realized a small qualitative survey on our 3 WhatsApp self-help group on non-muscle invasive bladder cancer. The names are low grade, high grade, and the third one is a smallest mixed chat called TURBT. 51 people out of 141 belonging to the 3 chats gave their answer. The highest number of responses, either numerical or in percentage, comes from the high-grade group. This is probably due to a deeper level of patient engagement of these people. But what about their risk acceptance? The 86.3% don't want to take any kind of risk. The remaining part is ready to accept certain risk under certain conditions. To understand better, let's see the group details. In the high-risk group, 21 answers out of 26 gave a negative answer. The most recurrent phrases are, I don't want to take any risk, obviously, or I want to feel safe. This second point relates to the stress caused by the fear of recurrence. Overall, anyway, the stress is considered an unavoidable condition. About the stress, 3 people out of 21 justify their answers in the following way. Paolo says the extension of time will cause or will increase the stress of waiting for results. Manuele, I admit that the follow-ups are stressful, but I wouldn't feel safe if I didn't do them. And finally, Maurizio, to me, waiting is the hardest things. In the other hand, those who have had a tumor in remission and whose follow-ups frequency has been reduced, they still don't feel safe. This is the case of Fiorenzo, but the case of Mirella too. Only one high-grade patient, respondent, is ready to accept the risk, but with a very provocative answer about the side effects caused by cystoscopy. Fiorenzo says, if my follow-ups were planned every 20 years, I would sign immediately. The remaining 3 people respondent of the high-grade group give a doubtful answer. Davide, one of the most engaged patients in the group, says the intensification follow-ups is possible only in view of a verified graduality or if replaced by new generation reliable urine test. And Alessandro confirms, I am willing to reduce follow-ups if replaced by the introduction of new generation urinary markers, perhaps alternating them with cystoscopy. Raffaello expresses the need to a personalized therapy and says various individual factors must be taken into account, such as anamnesis, psychological states, and especially age. Age, implemented by hetero-referred responsibility, as an essential rule for another member of the high-grade group. Manuela says, I am 44 and I have 2 children. The follow-up are vital because at the moment they are the only way to reduce the risks. And arrive to low-grade group with 25 responsive, 22 are not available for any kind of reduction of therapy follow-up. But also in this group, we have 3 doubtful answers. Fabio, Franco, and Pompeo echo what has already been declared by the high-grade members and says, no risk. I would accept follow-ups in the intensification only in view of new reliable tests, even alternative to cystoscopy. The rest of the respondents are oriented toward a negative answer. But I'd like highlight an important evidence coming from the surveys that 10 members require more frequent follow-ups. So I'd like to close my presentation. 44 respondents out of 51 gave a negative answer, therefore no risk at all. 10 of them require a more frequent follow-up, and these people belong to the low-grade group. And 7 people would agree with the intensification of follow-up if they are given a less invasive, valid, and well-guaranteed option. And this graphic gives me the opportunity to introduce a polyneural refrain about the non-muscle invasive bladder cancer. In our way, this disease is a lifetime marriage, and such as several marriages, during the first years, the treatments are experienced with the enthusiasm to be cured. As time goes by, the treatment becomes an unpleasant, annoying burden that at times patients would like to get rid of. I'd like to end my presentation with my personal point of view. The psychological factors affecting the quality of life of non-muscle invasive patients are stress, fear of recurrence or progression, doubt management, always having few certainties. And there is an lighthouse in denial for the patient. But the only reference point is for a patient is the doctor, obviously. And in my eyes, the way to improve the situation is a constructive doctor-patient relationship. In this case, the doubt management becomes a shared business, and therefore any change is possible in this way. Follow us the intensification too. Thank you.
Thank you very, very much, Dr. Fiorini. I think that the survey, the mini survey that you provided is extremely useful in my personal view, for making a reflection for our point of view, because the fact that the majority of patients with a low-grade recurrent non-muscle invasive bladder cancer, which is a disease that is not going to kill the patient in the vast majority of cases, they actually would not accept to take, let's say, missing a recurrence, which is going to be a low risk, is something that maybe make me thinking that probably the interaction patient-doctor is not ideal. I mean, probably we need to counsel the patient more. Also because this would be the basis, for instance, to accept the acceptance of active surveillance, which is a concept that more and more is coming into in the practice. But I don't know what is the view of my colleagues. We still have 5 minutes for discussion. Professor Wishes.
Yeah, Paolo, thank you for Eduardo, an excellent presentation, and I totally realize the anxiety for patients. So my argument is also not really to do less moments of follow-up, but just to change some of the follow-up schedule by a marker, like some of your people said, Davide and Alessandro. And one of the things you do have to realize, because one of the studies that Laura mentioned from 2000, we did a similar survey on the patients, and then we said to the patients, you know, the cystoscopy is 100% sensitive, and that basically is not the case. We know that from the blue light studies, we know that from the RETOR studies, and you know, so changing a cysto for a marker, I guess you will not lose a lot if you will lose something, and I guess maybe, and I really mean that, the markers are better than we do with our eye. But anyway, I totally realize how patients feel about that, the anxiety. So excellent presentation.
Professor Mariappan.
Thank you, Paolo. I would just like to echo what Professor Witters just said just now as well. And thank you so much, Eduardo, for joining the NMIBC panel as well. I think for the audience, it is important that we recognize patients' views, patient voices are incredibly important. And in each of your centers, or even in your healthcare setting, it's very important to take their views as to what is important for them in surveillance. For example, where I work in Scotland, there are a significant proportion of patients who don't want to come for surveillance because it's quite cumbersome. Whether it's biomarker or whether it's a cystoscopic surveillance, they might in fact even choose with the low-grade cancers not to do anything at all. So surveillance does not mean it's a be-all and end-all. So there are patients who choose not to have anything done, but come to you only when they have symptoms.
Yes, thank you very much. I think that this discussion has been extremely interesting. Unfortunately, we are nearby to close. I mean, Laura was mentioning a trial, which curiously, the best, I would say the best evidence, maybe we have a couple of randomized trials that were published this year on alternating markers with the cystoscopy, but definitely the one that was mentioned, it was on high-risk patients, surprisingly. So the cohort that we consider that we should probably be more careful. And Laura was pointing out, and that comes to the how much risk the patient are willing to take. That two high-grade tumor were actually delayed in their diagnosis. They were picked up at the cystoscopy at end of the year. And so obviously this, according to what has been said by Dr. Fiorini, this probably would not be considered acceptable for the majority of the patients. So maybe we will have to probably integrate these new strategies for the time being with some more counseling for the patient. So not just unless the guidelines will come up with formal introduction of the marker, which I probably don't see this as feasible at the moment. But maybe we will need to inform the patient. I don't know what you think, Dr. Fiorini, about that. What do you think?
I have to tell you that Alessandro, I mentioned before, expresses the idea that obviously is ready to take some risk, but having markers in addition with cystoscopies. But obviously, and Alessandro inside Palinuro is the expert of non-muscle invasive bladder cancer. So it's very, very, very well informed. Obviously, he knows very well your guidelines better than me for sure. And I have to tell you, frankly speaking, that several people is waiting for this market. But the majority of Italian patients, in any case, are not well informed about this novelty. And so for the majority of people, is the doctor, what you say to them is the most important thing. You have to drive the patient. This frankly speaking, I have to be honest, this is the situation. And as you said before, it's very important to have a more discussion to be a source of information from the. I understand that you have no time, but it's very important that you try to speak with your patient. And in this case, all the technical offer can be okay for the patient if you obviously doctor explain to the patient why to do this kind of surveillance or cystoscopies or urine test marker. The people is confident in the doctor. I said before, in my eyes, you are the light in the night. So
I think
people is really very afraid, if you understood, of their disease. Above all,
I think that we can take this message from yours as the take-home message for us, the faculty, and for our attendees this evening. And I want to thank you very, very much, all of you, for being here and for giving these excellent overviews and new avenues for the follow-up of non-muscle invasive bladder cancer. Thank you very much, and have a nice evening.